Welcome back, everyone. I'm Ruby Wynn, if we haven't met. I'm an associate professor here in the Division of Epidemiology and Community Health, and I'll be coordinating the division seminars this year, and I'd like to introduce you to our wonderful lineup so that you can come back again. We'll be discussing a wide range of topics this year, from anywhere from community healthcare access to specialty treatment services for women. We'll be also discussing the issues of nutrition, obesity, and even weight stigma. We'll look at multidisciplinary approaches to aging research and the role of causal inference in epidemiologic data analyses. And for you lovers of controversy, which I think there are some of you out there, let me highlight one upcoming seminar in particular. Lauren Gilchrist, who is an alum of our maternal and child health program, and also the Executive Vice President of External Affairs for Planned Parenthood, will be speaking on the sexual and reproductive health policy landscape on Friday, October 29th. So come back. But before we begin, let me give a brief statement to the students who have had their education interrupted by COVID. We've, the faculty.
Ruby, you went on mute.
Thank you. Let me start that sentence again. So back when I was a graduate student, way before TikTok, I would run into my chair of epidemiology in the hallway, and he would frequently ask me, so which famous epidemiologists have you met recently? And I realized that the reason he was doing that was because we had opportunities to meet in person, and we were able to discuss with people who we would only had read about or seen on TV. And in fact, if you look over my shoulder here, there's a photo of me and Sir Richard Dahl, one of the pioneers in making the association between tobacco smoke and lung cancer deaths. And this picture was taken actually after a seminar that he had delivered in my graduate school. So we understand, I think we understand what you're losing here as students going through school during COVID times. So what we've done here today is try to design something that will allow you a different type of access to these epidemiologists, one that we may not have experienced if we were crammed into 364, our seminar room, and listening to a didactic seminar. So I have asked Dr. Ryan Demmer to interview Dr. Michael Osterholm today. But before we begin, let me give you a couple of housekeeping notes that I've been asked to give you. If you want a transcription for the seminar, please press the transcription button at the bottom of the screen. And also, while this is an interview, we have left time for audience questions. So Dr. Demmer will be wrapping up his questions around 40 minutes past the hour, at which time, please use the raised hand function, and we'll see that you're interested in asking a question, or you can send it through the chat, but the question will only come to me and our group here, and we'll ask the question for you. Unfortunately, we know that we won't be able to get through all of the questions, but we'll get to as many as possible. So let's go ahead and start. For today, like I said, for today's session, Dr. Demmer will be interviewing Dr. Osterholm. Dr. Demmer is an epidemiologist and associate professor in the division. He focuses on the interface between infectious and chronic diseases. In the context of COVID, he's been leading efforts to better understand asymptomatic COVID transmission and the public health burden of long COVID. Early in the pandemic, he initiated a cohort of healthcare workers to inform the prevalence of SARS-CoV-2 infection among asymptomatic healthcare workers. The study is still ongoing, and he has expanded into a family study assessing infection burden among families of healthcare workers. Regarding long COVID, he is collaborating in a national consortium involving 50,000 participants to better understand who is at risk for developing chronic disability secondary to COVID. Now let me introduce Dr. Michael Osterholm. Probably he doesn't need much of an introduction, but let me do say that prior to joining the university, Dr. Osterholm was with the Minnesota Department of Health, serving as the state epidemiologist from 1984 to 1999. While at the university, he's been awarded one of the highest university recognition, which is the Regents professorship, and he is also the Ignite Presidential Endowed Chair of Public Health. You may know him as the director of the Center for Infectious Disease Research and Policy, or CIDRAP. During these pandemic times, he has served on President Biden's COVID-19 advisory board during the president's transition into office, as well as very recently. But around here, we know Michael as a proud dad to both humans and canines. So, welcome, Ryan and Michael, and thank you so much for doing this today for us.
Thank you. I just want to start out by one addendum to your very kind introduction. It's actually, I started at the university in 1975, and that was back when infectious diseases were a dead science. People often wondered why anyone would want to go into them. And it was almost like a surgical residency, see one, do one, teach one. By 1977, I was teaching infectious disease epidemiology at the university, and I have had a faculty appointment nonstop since 75. And actually for over 15 years during the 70s and 80s, I actually was the lone advisor for anyone going into infectious disease work at the university. It was a very lonely job at the time. HIV began to change that. And I'm happy to report that actually my very first PhD student was Dr. Craig Hedberg, who many of you know. So actually I've had a longstanding and nonstop relationship. I think my 46 years now put me up kind of towards the top of longevity at the school. and at least they haven't tried to kick me out yet, so I'll probably be around for a little while longer.
That's great. Well, I think thanks again for being with us, Dr. Osterholm. And as
Mike, please.
Mike, really appreciate it. As a quick overview for the audience, we're going to start with probably 5 to 10 minutes and just let Mike give us a rundown of where he sees things at this moment with the pandemic. And then we'll kind of move into a little bit of a back and forth with a lot of Mike and a little of me, just teeing up some hot topics. And with about 20 minutes left to go in the hour, we'll try and open it up to everyone. So take it away, Mike, and thanks a lot for being here.
Yeah, well, thank you, Ryan, and congratulations to the work you're doing. It's really very important efforts you're putting forward. This is a bit daunting to see all the faces on this particular screen because I know a number of you, and that's a gift. Let me start out by saying that there are two disclosures I need to make that I think that will help put some context to the words, what I'm going to say today. First of all, when I wake up every morning, I still have been doing that, even with the pandemic. The first thing I do is I hear this song in my head. For only a couple of you on the screen that were around in the 1960s, a singing group called The Fifth Dimension had a song called The Dawning of the Age of Aquarius. And I hear every morning, this is the dawning of the age of the variants. And it just continues to play and play and play. And then the next thing I do is after I'm out of bed, I reach over into my dresser and I pull out my crystal ball that at that point has about 5 inches of crusted mud on it. And each week it seems to get crustier and harder to break off. And so based on those two issues, the variance and prediction capability, I lay out kind of where I am and what I'm doing. I think we're at a point right now from a global perspective with this pandemic is just starting to mature. Most people want it to be done and gone, over with. It's not. What we're realizing, this is different than an influenza pandemic in that as opposed to having several waves where then it does become a seasonal virus activity, every indication we have here is that that's not the case. This virus hasn't done anything conventional yet. Anyone who, and we had many who proclaimed just 6 months ago this would become a seasonal virus like flu and that we wouldn't see a summer surge, well, that sure went by the wayside. Just 10 weeks ago, the two hottest spots in the entire world for transmission were Nepal, Pakistan, and India, and Uruguay, Paraguay, and Argentina. Same time. They were both at 30 degrees latitude. The problem was one was north and one was south. You know, hardly indicative of seasonal activity. So I think that what this virus is really just a coronavirus forest fire looking for human wood to burn. And what I don't understand, and I don't think anybody does, is it's a sprint virus, not a marathon virus. For reasons we can't yet explain, this virus will burn fast, it will burn hot, and then it tends to drop off. When there's still yet many susceptible people in that area, in that region, that could have become infected. And then another surge will occur later. and why surges do occur and don't occur. If one looks right now at the United States, why did the southern Sunbelt states take off again, just like they did last year? Why are we now seeing regional spread in the Southeast, in the far Northwest, and now to some degree in the upper Midwest, yet the upper and northeastern part of the United States and the southwestern part of the United States have been spared? Now you can say they're more vaccinated in some of those areas, but we know we have seen high levels of transmission, even in some highly vaccinated areas. Yet I can't explain to you why New York and LA are looking like they look like now. If they change, by the way, it will be a major change, because that will be then what will keep this surge really going. The second part of where we're going right now is another wild card. A year ago today, if we'd had a discussion about kids in school, I would have said, I can't explain it, but this virus does not transmit well in kids. It does transmit. We'd surely have pediatric cases and severe pediatric cases. But the bottom line is that for reasons it's unlike flu, where, I have over 40 years working with influenza, have always watched and said, well, as soon as we start seeing those community outbreaks in our schools, we're going to see widespread community outbreaks occur. It follows almost like hand in glove. We didn't see that with kids. And then along came Alpha, the variant Alpha. We saw it right here in Minnesota, saw it in Michigan, much increased transmission, 2 kids, by kids, and 4 kids. And then the summer came, schools ended. We still saw some events in the area of the sporting world. And then along came Delta. Delta changed it completely. Kids readily get infected with this virus. Kids readily transmit the infection with this virus. And it's changing the epidemiology in terms of how we worry about community-wide transmission. I would say right now, as we sit here this morning, there's over 1,400 schools right now in the United States, 39 different states that are closed, not just reduced performance, they're closed because of COVID transmission. We're starting to see it in our colleges. This is going to be a substantial issue for us going forward. We are not prepared to provide safe education for kids. Safer potentially, but if you look at, and we can get into this on the recommendations, what we're talking about for kids, I think is going to be a huge challenge. Is there more transmission with kids? Yes, absolutely. Is it a more severe disease? I don't think we know. We still have a challenge. Are we just seeing a bigger piece of a bigger iceberg, or is the top heavier in this same sized iceberg? One sobering fact right now, from September 3rd to September 2nd of this year, we've done that. We're updating those numbers this week. There were 341 kids who died in this country from COVID. 66 of those deaths had occurred just in the last 3 weeks. So that you get the sense of also what's happening in pediatric transmission. Now, there's lots of questions about vaccines. We can go into that and talk about what we know there. But I think the bottom line message is we're in for the long haul. There is not going to be a concept of herd immunity here. It isn't going to happen. Between the issues of waning immunity, between the issues of just what we have to achieve to get people so that there isn't transmission, I look no further than what's happened in the UK and Israel, 2 countries that are much more vaccinated than we are, and they're still having challenges. And this is an example of what this surge does. If you look at England in particular, or look at the UK, I'll call, is an example of before Delta occurred, they had gotten down to about 1,900 cases a day in May. Then all of a sudden a Delta surge occurred in the UK in a much more vaccinated population. They got to 54,180 cases a day on July 17th. On July 26th, the numbers dropped precipitously by that time to 24,600. Everybody said, haha, look at, we're on our way, we're done. Well, then guess what happened? Now they're back up basically, UK today is at 38,000 new hospitalizations a day. They're up to 8,000 hospitalized. There's 38,000 new cases, 8,000 hospitalized, 167 new deaths. Deaths and hospitalizations are down versus previous surges, but the transmission has been remarkable. And so I think that if I'd open this up and say, this is going to be a learning opportunity for a long time. We need epidemiologists to help us understand what this virus is doing, why it's doing, and be prepared to potential pivot as we learn new things. I mean, just one of the challenges I've had with policymakers has been they are still living in last year's model for in-class education for kids. We all want kids at school, everybody. But the problem is, how are we doing that today safely? It's not just safer, but safely. And I think we're still in last year's model, and that's causing us a great deal of issue. I think the idea of how long this is going to last is in some ways lost on this country. How long does it last in the world? 3% of the African population has had access to vaccine to date. We want to worry about a variant spinning out that could potentially threaten the integrity of our vaccines in terms of the issues of immune protection. It's going to come out of a variant that's from a place like that. And that's why we have an obligation, not only from a humanitarian standpoint, but from a strategic standpoint. We got to vaccinate the world. And that's going to be a real challenge for us right now. So I'll leave it with that, just saying that anybody who wants to get involved studying COVID viruses right now, I guarantee them they're going to have a lot of very rich material to work with, and it's not going to get over soon.
That's a great setup, Mike, for where we want to go today and what we want to talk about. I wanted to put a little context to what you talked about in terms of deaths in kids. You gave very fresh numbers in September, and I was just looking this morning. In the month of August, just this last month, that was the highest number of deaths in kids 0 to 17 that we've seen throughout the pandemic, as I'm sure you know. Yep. And even in the 20s, 30s, and 40s, highest numbers of deaths in each of those respective age groups just in the month of August. So it certainly suggests that Delta is taking a toll on younger people. Sticking on variants for a minute, because it's such a hot topic and that's all anyone can talk about, and it certainly changed the game. I'm curious what you think about the surveillance system we have in the US for monitoring variants and its ability to inform public health action in real time. Is it good? Is it bad? What change is needed? What are your thoughts on that?
Well, let me just say, first of all, we started out in a miserable position. We were in basically the first 6 months of knowing that we needed to look at variants very closely, basically sequence in a very limited number of viruses, such that we're now doing more each week in this country than we did back then. We still have holes. We have states like Wyoming that are sequencing 20% of all the viruses that are coming, that they pick up, whereas you have other states that are less than 0.2%. And so it's a function of in between. I think that we're going to see improvement overall in the sequencing capability. The next challenge we have is how are we going to use it? I think the US has really suffered miserably from having expertise in large data sets. Right now, we get far too much of our information on vaccines and what's happening in the population from places like Israel and the UK. And I think, I say this as a very dear friend and loyal supporter of the CDC. This has not been CDC's finest hour. And I think that we need to really deal with that. And this is one of those areas right here, is looking at the variants. I will say that, we have to keep our eyes wide open on variants. We don't know what's coming next. As I've already talked about, the three buckets, either, it's more severe illness, more transmissibility, or the issue of evasion of immune protection that we're concerned about. But right now, Delta seems to have cornered the market as the highly transmissible virus that seems to be beating everything else out. We're looking right now head-to-head at Mu, for example, which emerged first in South America, which does raise some questions about its ability to evade immune protection. And yet, wherever Delta and Mu are coming head-to-head, Delta wins hands down. So transmissibility seems at this point to be the key feature that is directing how well these viruses do. And I can only imagine with some fear, if Delta is going to be replaced, it's going to be replaced by a virus that's even more transmissible than Delta. And that just doesn't seem possible. And let me just talk about transmissibility just one last moment, because I think this is where variants come into play. Our own Minnesota Department of Health, which I will acknowledge right up front, I have an intense bias, I'm sure, here. But I think it has done as good a work as any state or local health department, and in many cases, federal health agencies in the country around this pandemic. And one of the things that they've been really working on is tracing the issue of outbreak sources. And they have now documented over 50 outbreaks associated exclusively with outdoor air. That is remarkable. That was not what this pandemic looked like the first 12 to 16 months. And that really is I think, attributed to the viral loads, the infectiousness of Delta, and what that means. And that is an indication of just how infectious this virus is. I can't say that this virus is a flu or is a measles virus, but there are days when I see some of these transmission events, I go, oh my God, this feels just like measles. So it's a pretty substantial variant in of itself.
So it was sobering to hear you say at the outset of your response that you basically don't see us reaching any sort of herd immunity, and that concept that we were hoping for may not be present. And based on what you're talking about with the UK data, where 90% of serological evidence of prior infection or vaccination, and yet their case rates are as high as they were last year, is a little bit scary. So the question is, from a surveillance metrics point of view, what numbers should we be watching? Should we even be paying attention to infection if we can't control it? And should we focus more on symptomatic illness and hospitalization?
Yeah.
And what metrics do you look at a daily basis after you dust off the crystal ball?
Well, thanks, Ryan. That's a great question. Well, the first metric I look at, am I still alive today? Okay. Well, that's a good one. Check that box. Okay. How are my family, friends, and CIDRAP colleagues doing? Check that box. How are the rest of you doing? Check that box. So those are some of the metrics right up front I look at very carefully. At this point, one of the huge challenges, and I've raised this issue a number of times to the point of where I feel like nobody wants to hear from me anymore, is, we've never really had a goal in trying to deal with this virus. If it was a goal at all, it was just to get through it. And no one knew quite what that meant. Then I think it became a deferred position of, well, we can't let our healthcare systems break. If they bend, that's okay, but we can't let them break. Okay, which in fact we've seen now happen in a number of locations in the US where they're broken. They literally broke. And we've never articulated what our goal is and what's acceptable. I've tried to raise the issue on schools, for example, and said, well, okay, how many deaths might we expect in a given year from influenza? And CDC actually does have really good data on that. Is that a model that if we have that with our schools and kids, that's what we should expect would be acceptable? Because we don't shut down schools very rarely for flu. That's not an issue that we consider to be sufficient. So maybe that's the metric we use. But we've never made that decision. We've never decided. Now, other parts of the world have gone just the opposite, and we're watching this play out. Many countries chose a zero tolerance policy where we're going to just contain it completely. China being the most notable of those, and they've had their challenges recently, but they've done it. But then you've had countries like Australia, which took on the same policy, which has now decided they can't control it. It's no longer zero tolerance. It's trying to just keep the case numbers down without really articulating what that means. Same is true with New Zealand. And so I think that one of the things we have to do as a world is come to some agreement on, given your country, given your location, what is the policy or the approach or the priority that you're trying to accomplish? Because that'll say a lot about vaccination. That'll say a lot about where we're at now. I think we're in a grand experiment in this country right now with what the president announced yesterday. We're already a very torn country. I don't need to tell you that. You all know that. But now with these new mandates, which already have elicited judicial review and litigation, what's going to happen with the mandates? What if people say, hell no, I'm not going to? And there are people who will do that. How torn will we get over this? What are we trying to accomplish? So I think that I wish we could have more discussions about that. In an idyllic world, what is it that we're trying to do? I think I tend to be one that says, well, if nothing else, we have to protect the most vulnerable. Okay, what can we do to protect them? Our children, our older age populations. I think, to use as an example, one of the challenges I've had with long-term care has been the deplorable vaccine situation there, where in many places in long-term care, we still have fewer than 50% of the workers vaccinated. Well, that has surely been a spillover event time and time again for transmission in terms of long-term care. But why is that the case? Well, look who works there, how much they get paid or don't get paid, and where they come from in the world about vaccines. And we've missed that opportunity to understand this is all about the under compensation and lack of appreciation of who works in long-term care. You know, when I have a long-term care administrator say to me, please do not mandate the vaccines here among our staff. And I say, well, that you don't want to have cases in your residence. I know that, he says, but if you do that, they'll all walk off the job. And then who's going to clean grandma's bed? You know, and then that's a very sobering kind of, you know, juxtaposition. So I think this is a long-winded answer to say that there's a number of issues that have to be addressed about where are we going with this pandemic? What are the social, political, and economic issues? What are we willing to accept? And then let's all articulate that so that people know what we're trying to do.
That makes a lot of sense. Clearly articulated goals and priorities. I couldn't agree more. And it reminds me of something that you said frequently throughout the pandemic, which is that hope is not a strategy. And the quicker we can move away from that thinking, the better. So you mentioned vaccines, another hot topic. Let's shift to vaccines and talk about that a little bit. There's been a lot of confusion about vaccines, as you know very well, from safety and efficacy to need for boosters and the appropriateness of mandates. So let's talk about a few of these issues, starting with your thoughts on boosters. And my question is, will they become the norm? And given how nimble the mRNA vaccine production can potentially be, are we going to move into an era where we're getting vaccine updates, much like you update your computer operating system against new viruses? Will we be getting new mRNA-based vaccines for the newest variants in the future?
Thanks. Another really critical question. Well, first of all, let's take a step back. Think about where we were at the beginning of the pandemic. The moonshot concept of basically having vaccines in a short period of time that were effective against this virus was just that, a moonshot. Okay, Operation Warp Speed, what a name, bad name. But at the time, the expectation that had been laid out, given what we knew about coronaviruses, was, man, if we get a vaccine that's even 50% effective, won't that be great? I mean, that was considered like our minimum standard. That's what FDA actually said right up front. If it's 50% or more, we'll license it, okay, if it's safe. Well, then we got the first data out of the mRNA vaccine trials, where within 3 weeks of dose 1, we started to see levels of protection. And we didn't even understand why, because based on the immunologic profile, we weren't even seeing that much antibody develop. So obviously T cells were playing some role. But then suddenly we went to this whole new level of expectation. Oh my God, these vaccines, 95% effective. We're going to get them made quickly, get them in people's arms. And there was almost a euphoria about that without articulating, wait a minute, now we still got some time to go here to figure out what this may look like after 1 month, 5 months, 10 months, etc. But we've laid out this idea of this very, very high level of protection. Well, we remember when we set these vaccines up, the whole point was we had to get them licensed as quickly as possible, at least approved through emergency use authorization and to licensure. And so the original clinical trials were set up so that you had dose 1 today, and dose 2 was 3 or 4 weeks later for the mRNA vaccines, of course, dose 1 only for J&J. Well, if you talk to any immunologist who has studied vaccines over a lifetime, they'll tell you, you know, the immune system response is not based on our timeline, it's based on what it does. And if you look at immunologic response, you want to stress the system with that first dose, and then you want to have some recovery period. And there were those that argued that actually delaying 8 to 10 weeks to dose 2 would be much more beneficial, but it cut against the grain for short-term immediate protection, which is what we were trying to get at for the pandemic. So there was never really an articulation of what is the maximum dose spacing. You know, it was more around dose amount. And so by not having that, we laid out these 2 doses, you're good to go, go for it. We never really had anticipated the issue of waning immunity. And the idea that, you know, maybe over a period of time with just that 2-dose approach, that wouldn't work. We've seen that with other vaccines. Hepatitis B vaccine is a good example. It's a 3-dose vaccine spaced out over months to maximize on the overall immune protection. And so what happened was we started seeing all these breakthrough cases, which initially were downplayed in a way, not to say downplayed inappropriately, but, you know, there are only a few, okay? Well, now, as you know, a third of all the cases reported this past month in Minnesota are breakthrough cases. Now, that is to be expected in part if everybody were vaccinated. You'd expect to see only breakthrough cases in vaccinated people, but you'd also expect the numbers to be way down, you know, 100% of 20 versus 20% of 1,000. And the point is that we never really thought through, how do we maximize the performance of these vaccines? We worried a lot about the bucket of safety, which we should have. And we can report these are incredibly safe vaccines. So that's off the table. We're not debating or discussing that. But how to best use these vaccines, I think, was a missed opportunity, because we've now left the public with the sense that we're all confused. We don't know what we're doing. We're not quite sure what to do. And I think that this has been an experiment that we could not have done any differently initially to try to get the vaccines out. But for example, I have very strongly discouraged the concept of a booster dose. To me, it's a three-dose prime. I've seen the data immunologically, and I can tell you that if you look at the three-dose approach on an mRNA vaccine at 1, 3 weeks or 4 weeks and then 6 months, you go from like a very limited increase response with dose 1 to a much more moderate response dose 2, and a very dynamic response at dose 3. And I think that ultimately what's going to happen is that we will have a 3-dose prime vaccine that will be spaced out more. We're looking clearly at the data now from the UK and from Canada, where because of a vaccine shortage they had early on, and they were worried about alpha as getting 1 dose into people, with alpha occurring in November, December, and January, they went to a dose 1 now and dose 2 10 weeks later. And there are some who the data looks like that might even be advantageous, to go dose 1, dose 2 at 10 weeks, and then dose 3 later on. So I think ultimately we just have to be prepared for corrected science. We live in a world of corrected science. People have a hard time understanding that, where what we're doing is we are building the 747 at 30,000 feet as we're flying it. And if safety were an issue, that wouldn't be acceptable. But if it's about how to maximize the use of the vaccine to get the most out of it, then it is. And so stay tuned. I think you're going to see over time additional changes made to the overall dosing schedule, how much, the issue of what can you do to mix and match. I mean, for example, many of my dear colleagues who are what I consider some of the best vaccine immunologists in the world said, in their mind, the ideal would be adeno platform vaccine first and then mRNA vaccine, because of how the two act differently with their immune response. Now, can you imagine anybody talking about that right now? But that very well may be one day how we will approach this. So this is going to go through a lot of churn, a lot. And what I worry about is people will interpret this as absolute misinformation, disinformation. They'll say, see, look what you said back there. You said that back then, and now you're saying this now. You don't know what the hell you're doing. And I think that's what we have to prepare for, because we are trying to maximize these vaccines to have the most impact.
Well stated. Science and decision-making changes because the virus changes every day and it's brand new. No surprise there. So we've got about 8 or 9 minutes until we shift to the more broad conversation and invite other people in, but I wanted to go to a few more things. Before we leave vaccines, mandates. What are your thoughts on them? Do they work? Do they not? Where do they work?
Well, I'm a very strong supporter of vaccine mandates, and it's because I believe that the public's health takes precedence over the person's health. And I've said that from the very beginning. It was interesting because if you'd seen all my hate mail I got at the university after I'd come out opposing a mandate at the U, you would have thought I had, basically sold my soul to the devil. And my whole opposition to the university's initial concept of a mandate was that they were going to allow for an exclusion, that anyone could exclude themselves. Didn't have to be religious, or did it have to be due to a medical reason? And had we done that, put that mandate in place, that would have been a disaster, because anybody could walk through it and it wouldn't be a mandate at all. It would make us all feel good. People misinterpreted that as suggesting I didn't want a mandate. I didn't want that mandate, because to me, that was going to be a problem. And if you're going to do that one, don't do it. Give us time to work with people. But once the exclusion was removed, then I was very supportive, because now it forces people to go through either a religious or a medical exemption to get exempted. I know people say this is personal freedom. I understand that. But in a sense, from a public health standpoint, we have a historic understanding of what we need to do for community. And when the ACLU comes out saying that mandates are not only appropriate and legal, but that in fact they do help deal with the the distribution of vaccine in a way protecting those who are vulnerable. I thought that was a pretty strong statement. So we'll see where it goes with this point. I know that it is surely going to be locked in litigation over what the president has now recommended, his executive order last night on what government contractors and government employees have to do, et cetera. But I think it's the right thing. You know, we as a country, as a community, as our governments, just because somebody wants to get intoxicated and drive doesn't mean that they can do it just because it's their right. We take them off the road the best we can because of the harm they do to others. People who are unvaccinated today are driving this epidemic within the United States as part of the global pandemic, and that's just not right.
One more quick question on vaccines. You famously spoke with the Minnesota Vikings recently about vaccination. If they win the Super Bowl this year, I'm going to call it the Osterholm effect. The reason I bring that up is, how do you talk with people who are vaccine hesitant? What's the most effective strategy that you've found to communicate information in a non-judgmental way?
Well, you know, the first thing is trying to distinguish between those who are vaccine hesitant and those who are vaccine hostile. You know, we've never really characterized them in those two categories before. The vaccine hesitant are truly people who are looking for more information or want validation. You know, on my podcast this week, I read an email that was incredibly difficult for me to read, but it was from a listener whose sister had just died of COVID. They had just buried her, 38 years old. She was pregnant, and they basically took the baby by C-section 3 days before she died, and the baby survived. And the whole point was she wanted to get vaccinated, but her OBGYN told her not to because of the fact that they hadn't shown that the vaccine was safe yet. And she was more concerned. And, you know, that was not an illegitimate concern, but, you know, we blew by that a long time ago. And the College of OBGYNs have, you know, come out and said, no, get vaccinated. It is safe and it's what's critical. In a setting like that, I still find that there are a number of people who believe that it is dangerous to get vaccinated during pregnancy. These are people who often are vaccine hesitant, not hostile. And so you work with them. You give them the information they need. You help support them through this. You give them an understanding of why. Many people have had the various immunologic challenges in their lifetime where they have this belief that any vaccine could be dangerous for them. You work through what it is. So I think there we owe people a lot. We owe people a lot. You know, I've been very involved with Stephen Thomas and the group out at the University of Maryland, the Black Barbers and Black Beauticians group, where I have watched firsthand in these barbershops where young Black men who have every reason to be challenged by a US government effort, given historic perspective, where over time that can be changed with factual information and peer-related education. So there again, I think it's vaccine hesitant. Vaccine hostile, they are not going to get vaccinated. I mean, you know, ideologically, they are just not there. Now, at that point, I have lost all empathy for that group, particularly as they put others at risk with misinformation and, more importantly, disinformation, okay? I mean, you know, we have a state senator who is who is basically sharing right now disinformation around the fact that 220 Minnesotans have died from COVID vaccine. You know, that's not acceptable. And that's not negotiating anymore. That's about using the powers of public health that we have. And I think that that's really important. Now, you're going to get shot for that. I mean, one of the things I think some of you know this already. I see some of our staff on here who know it well. You know, having been in this business for 46, almost 47 years now, you know, I've been through some tough days. You know, I was very involved in the early days of HIV/AIDS. Maybe many of you don't know this, but Minnesota was the first state in the country, the first government in the world to make HIV reportable at a time that gay men had major concerns about they're going to be marched off to an Auschwitz-like environment because of HIV/AIDS. Of course, we needed it because to try to respond to the unfolding pandemic of HIV, we needed not wait until they became AIDS cases. despite having been involved with all of that, never had I received a death threat. They're not unusual for me right now. I mean, I share some of my emails with the staff and they'll tell you, I mean, it's incredible what you have happened today. These are not rational people. And so I'm very willing to use the fullest powers of the law to address these issues with them so that they might protect others. You know, what it is for them, I hope they're protected, okay? And I want them to be protected. I don't wish them ill will, but I don't accept their vaccine hostility anymore as acceptable, and we shouldn't. We should be just damn mad and not accept it.
Well said. Completely agree. So one last question before we move to the open session. Epidemiologists and public health professionals more broadly have really come into the spotlight. Myself, in the last 6 to 9 months, most people I meet don't ask if I deal with skin diseases anymore. They have a little bit better understanding of what epidemiology actually is. So I just wanted to ask you, given the fact that you've become even more widely recognized as an expert in public health and infectious disease through all of this, talk about that a little bit in just a couple of minutes. You know, how do you approach conversations with media and government and decision makers? And the ultimate question I want to ask you is one that I'm stealing from you that I've heard you ask, which is, when this is all said and done, to what degree will ever be done with COVID, what do you want your legacy to be on COVID-19?
You know, I've never had a question asked quite like that before, Ryan. So, you know, I think the most important thing is that I told the truth. Now, grant you, the truth is going to be a relative term in terms of the corrected science that I talked about. You know, it's going to be that. And so I always lay out there what I know and don't know. And, you know, I'm not afraid to say, I don't know this. This is what my best guesstimate and why. So I think that it's really important. But, you know, for example, I have, you know, again, some of you on here know well, taken lots of right and left punches over positions I've taken early on. I, back in April of a year ago, challenged the idea of masking. Not because I wasn't for masking, it was for quality masking, because we had evidence back then that this was an aerosol-related transmitted virus. And we knew that face cloth coverings provide very limited protection. And so we talked a lot about the quality of the masking, even though we very rarely hear that ever discussed. And at the time, I was put into a bucket of anti-masking groups, and it wasn't that at all. I mean, that was a total mischaracterization of my position. And I had to constantly go back and say, no, that's not what I've said. This is what I've said, okay? And I think that has been a challenge because you can't nuance with this disease. People won't accept it, but you have to keep at it. And so today we're starting to see the quality of, I think, some of those conversations where we've now seen CDC now embrace the fact, yes, aerosols are important. WHO has done that. Still big challenges at CDC getting documents out. And even much of the studies that have been done, and I see Angie Ulrich's on here and others of our group that are working on looking at the concept of respiratory protection, is we have such a bias today towards finding studies that support the kind of masking that by explanation is not a valid study. There was one, an ecological study that was done recently that was written up in the New York Times, an entire op-ed piece about following 1 million mass students and protected them against COVID. What it was somebody looked at a time period in North Carolina when COVID activity was at a low, and the one thing that they said was common practice was masking, therefore masking protected it. You know, speaking out about the quality of studies has been something that is hard to do because it's not always popular, but it's really important. So I think, you know, for me, it's about honesty and just trying to get us through this pandemic with factual information, you know, not allowing to get distracted by those who are going to try to use whatever words you have. And you know, I've actually read quotes in media that I read in this quote and I'm going, who the hell said that? According to Osterholm, what? So I think that it's one of those things where you also have to be prepared for that. But the last thing I would just say is, this has been a tough time. It's been a tough time, but it's also been in a very special time. I am the luckiest guy in the world to work at CIDRAP. The team of people I work with at CIDRAP are just simply incredible. And so that experience has been really very, very special. And just, the school itself, the university has been very, very supportive. So if I was remembered for anything, I guess that, I made it through the pandemic.
Thank you, Michael. Thank you, Ryan. For now, Ryan, if you feel free to ask questions too, Ryan, I'm going to summarize 3 questions that we've received into one. Michael, how do we get ourselves out of this pandemic? Does it look like we'll be going into more lockdown? Or do you think other approaches such as confirmation vaccination are needed to get us out?
Yeah. Well, first of all, we're never going back into a lockdown. It won't happen. Politically, it won't happen. There's no appetite anywhere for that. And I think that's, again, another example of the nuancing issue. I published an article last spring, a year ago, and said lockdowns are not the way to approach this as a general national lockdown. And of course, that came off as, again, anti-public. I said where there's evidence of transmission, then do it. But if you hit many rural areas of America right now with a lockdown for the next 6 to 8 weeks, and there are no cases, you've lost your chance to ever use it again. And sure enough, that's what happened. That's actually one of the breeding grounds for some of this anti-vaccine, anti-public health activity. So I'll just say right now, we're not going to go back to a lockdown. And we're not going to get out of this right away. We're going to continue to see these surges. Now, will there be one as big as this one again? I don't know. Just think about this. As of today, we estimate that at least 72 million Americans who are eligible for vaccination have not been vaccinated yet. That's a hell of a lot of wood for this coronavirus forest fire to burn. That's not insignificant. And so could we have more surges like this? Absolutely, we are. We will. Whether they'll be this big or not, I don't know. As I said earlier, will New York and LA heat up in the next 6 weeks? I don't know. But they will again. So I think we have to get used to this kind of roving surge activity that will continue to occur, go up and go down, go up and go down. And that's what's being seen globally right now. Iran just went through their 5th huge surge, and they had the highest number of cases of any of the surges to date. And so I think we just have to expect that. That's a psychology issue in of itself, Ruby, is also preparing people to say, this isn't going to be over with in the fall. This isn't going to be done next winter. I don't know how much it will be, but it's not done yet. And that's the part where more vaccinations we get, the better we'll be.
Here's another question. Given that the sequelae associated with COVID infection is worse among people with comorbidities, including obesity and diabetes, are we missing an opportunity to bring those issues to the forefront?
Yes, and yes. Huge issues. This should be one of public health's finest hours to actually address that issue. The challenge is, how do you deal with obesity versus ivermectin? And I don't know. But I think this is a really important part of public health. This goes to the very foundation of who we are. So I think the kinds of studies there. And, it was interesting because in the early days of HIV/AIDS, and Jim Neaton and the group here led a lot of this, were the studies about comorbidities with HIV and how important they were and what you could do to reduce risk of, before we had the kind of therapies we have today. So I very strongly support that kind of work and think it is very important.
Michael, this is from Ellen Lifton. You've been thinking about masking a lot. Can you expand on recent evidence of the efficacy of masking and masking mandates?
This is a real challenge. We're actually writing a commentary that will be on our website soon on the masking issue. And one of the things that I really am concerned about is the bias that's into these studies. All of these studies that have recently come forward have challenges with them that were never addressed. The most notable is not one that's a fault of the investigators or anybody involved with the study, is they were all done before Delta. Delta has fundamentally changed respiratory protection and what happens. So how to interpret those results are critical. The second piece is the one, for example, the study from Bangladesh. I know the investigators. I can tell you right now, there's some really serious challenges with the methods in that study. And there was a preprint that hit on day one, because I got it they sent it to me. The second day they were in the media with it. And everybody who wanted to believe that this study now showed that face cloth coverings were highly effective, just look at the largest study that was ever done, so therefore it's good. And there were a lot of limitations with this study. And I would hopefully tell you that I would offer the same critique if the study showed it didn't work, And, we've been working with the group at CMS, that CMS supported investigators who have been doing routine updating of this literature on respiratory protection. And they have yet to find anything that shows that face cloth coverings provide any adequate protection. And in fact, if you look at the data that is NIOSH generated, looking at face fit, and look what's happened there, using the CDC assumption that there is a 15-minute window of exposure, close contact, where you can get infected, i.e. time plus dose, concentration, combination gets you infected. Well, that was pre-Delta. So clearly, even less than 15 minutes exposure can do it. But when you look at the data, looking at the various studies that NIOSH did, face cloth coverings give you about 5 more minutes of protection than 15 minutes. A surgical mask gives you about 10 more minutes protection. An N95 respirator unfitted gives you about 2.5 hours of additional protection, and an N95 fitted gives you more than 25 hours of protection. Now, do we ever talk about that? The quality of masking and what it means? Do we ever educate people about the fact, we've been doing a study where we freeze frame media events routinely, indoor and outdoor, and then go and look at who's wearing what for face cloth coverings, and then we look at what they're doing. We consistently have seen since the beginning of masking 25% of people wearing it under their nose. That's a damn chin diaper. That's like fixing 3 of the 5 screen doors in your submarine. And yet we never hear that discussion. Just this past week, I have 3 different photos of President Biden out and about in the public, which God knows he's good at, where people have face cloth coverings on below their nose, right up in his face. Who would have let that happen? I keep telling the administration, you got to get a better press person to deal with that, okay? But the bottom line is we don't get it. So I think, Alan, to answer your question is that the data are very limited in face cloth coverings. There's more evidence that you get better protection with surgical masks, but it really does require the N95s. And again, just think of this. If you want to understand CDC's current recommendations that you can put kids up to 3 feet apart in a school with a face cloth covering on, smoke is a classic aerosol, both large particle, small particle, okay? If somebody was smoking next to you 3 feet away and you had a face cloth covering on, do you think you'd smell it? Hell yes. I had so many reports to me. I actually had many people who commented to me during our summer forest fire situation where we were so smoky here in the Twin Cities, how many of them were wearing some kind of face cloth covering and they were choking in the smoke. So, part of the challenge is that even though it's hard, we don't have the luxury of just painting a picture that is what we want. We have to paint the picture that is. Now, let me just comment. Minnetonka School District just bought 300,000 N95s and KN95s fitted for kids' faces. It can be done. These respiratory protections out there. We're moving the University of Minnesota to all N95s, KN95 protection. So I think that we want to be really clear here. It's not that we're against respiratory protection and masking. We're for it. But if anyone who's ever done any work in the indoor air knows that the number 1 thing is ventilation. Number 2 is if you can source reduction, i.e. who's there. Number 3 is testing can help, but masking always is at the lowest level. It's the least effective of what we have. What are we doing in all these other things? So Hope that's helpful. Sorry. You can tell this is a topic that's near and dear to my heart.
It was very helpful and important to hear it in that detail. A quick question came in circling us back to vaccines from Diane Newmark-Steiner, and she's wondering, should the university's mandate include proof of vaccination, like some sort of physical proof, take a picture of your card, as opposed to just clicking the vaccinated button?
Oh, well, first of all, I very much appreciate the sentiment, Diane. You're right on the mark. Okay, we've already had evidence in other colleges and universities of false documents being provided. I mean, hell, if you can be a teenager today and go out and get a false driver's license, go drinking, how hard is it to duplicate one of these cards, which right now is not a high standard. I mean, it's really easy to do. So I think it surely would add another level of challenge if somebody wanted to really, really not tell the truth. They could go and get one of these cards. They're actually on the black market, easy to get right now. You can get it on the internet pretty easily, so that somebody could still provide proof of vaccination with a fictitious document. So I think that I would like to have it all be, I wish, this is where I wish we were Israel or we were UK, because the medical record, electronic medical record, can link up immediately, and you can find out, were they vaccinated? Where were they vaccinated? What were they vaccinated with? And you can validate that right now. We don't have that. This is if anything, this pandemic has just exposed the underbelly of the challenges of our healthcare delivery system and all the issues and shortcomings thereof. So I don't know if it makes much difference. If somebody's going to cheat and lie, they're going to cheat and lie.
This is from Kate Eckroth. Michael, can you put your advisor hat on? When advising a policymaker, what incidence rate are you looking for in order to suggest that, for example, the mask mandate can be dropped?
This as the reason I'm doing this presentation today. It helps educate me. This is kind of like the definition of pornography. I can't tell you what it is, but I know it when I see it. And I think that the challenge we have is, if it's one number, it doesn't reflect necessarily what impact the disease is having in the community. What's it doing? Is it really challenging us in our schools? Is it challenging us in our workplaces? And is it acceptable to our elected officials? Our academic oriented data sometimes means very little to a politician. It's about what the influences are. What does it mean? Are you going to have a bad vote occur because of it, where you may lose a commissioner of health or something because of this policy? And so I think this is really a study in public health policy that involves a lot of other people. It's ethics, it's government, it's so forth, as to what are we trying to achieve, what do we want. So to me, I don't have a number. What I would have is a group that I already mentioned this early in my conversation here, is that we need to have that discussion about what are we trying to achieve. Was it wrong to be where we were at last May, where people were feeling much more open and confident? I would say actually that wasn't wrong. But then something happened. Now, what I have a problem with is people assume, well, what happened was because people started to open up. Well, that's not true. They're open up right now in LA. They're opening up right now in New York. Broadway's back on, and they're not seeing a problem. Now, what are they doing? Okay. So I think that this surge issue is going to come up and down, and I think we're going to adjust to times when cases are on their way up and healthcare is challenged, and cases are on their way down, and people can go back doing what they're doing. If you look at Minnesota right now, you'd be hard pressed to convince people that they shouldn't be at the Vikings game, or that they shouldn't be at the Gopher game, or that they shouldn't be in shopping malls, etc. if you go look at the crowds. So I think it's more about what is socially acceptable along with what public health would say. Ideally, I'd like to see no transmission. That's not going to happen.
A question that has come in from a few people. Do you think social media has helped or hurt pandemic response?
Both, clearly. But I think we've understood for the first time the power of disinformation and what it can do. It is remarkable. And I think that, we've always known that in the anti-vaccine world, but for the first time, we're seeing it across the board in a way that is really challenging.
Great. Maybe time for one final question, summarizing many questions again. Talk a little bit about modeling. How can it be the most effective? It seems like there's sort of the investment approach to modeling, which is a bunch of fixed assumptions and where you'll be for retirement earnings 3 years down the road versus predicting the weather. And where does infectious disease modeling fit in that spectrum?
Well, first of all, unfortunately, I have to leave in just a minute here because I'm on another one. This is one of those days. This is my 4th hour and going into 5th hour here. Modeling is a huge issue. And it's a huge issue, not just because of what it can do to help us, but what it can do to harm us. And I've had to deal with the downsides of modeling where estimates were made that were far, far out of the realm of what happened. And the implications from the political side have been dramatic. And I've seen actions taken or not taken based on modeling data, which ultimately showed to be wildly inaccurate. And I think that it really gets back to what are the limitations of modeling, what are the strengths? What's the time period? Anybody that puts a model out for 6 or more months today on COVID is using pixie dust. I mean, I think we have to acknowledge that. And it's just one of those issues. So I mean, I want to give it much more justice, and it's just to say it's an important topic. It's one that can be informative. I think the ensemble modeling that CDC is doing right now with all the different groups involved, no more than 30 days, is helpful. But I think that other modeling has surely been very, very challenging. So sorry with that. I didn't get much into it, but I'm going to have to run here.
Yes, thank you so very much, Michael.
Thank you. I hope this was helpful. Thank you. Thanks, Ryan. Great job. Thank you. Thanks, everybody. Bye-bye.
See you next week.